Butterfly rash can be very florid, like in these patients who have scab over the lesions. But importantly, we should not miss these rashes, which are not very prominent, like this young girl who had rash over the nose only. So these patients, ANA was positive, she had mild alopecia and arthralgia, turned out to be SLE. So we should not miss these patients also. Males are not immune to butterfly rash or the diseases which can cause butterfly rash, like this young male, but he does not have SLE. What he has, will come to that later on. But all rashes in the malar area are not because of systemic disease, like this lady. She does not have any systemic disease. What it is, again, we'll discuss later on. So when a patient presents with facial rash, what are the differential diagnoses we think of? It depends upon age. In infants, atopic dermatitis can give rise to facial rash. In adolescent, acne vulgaris is more common. Acne rosacea usually occurs in the age group of 30 to 40 years. Seborrheic dermatitis can occur at any age. Systemic lupus or discoid lupus usually affects young adults, especially females. Dermatomyositis can affect both children and adults, and sarcoidosis, where you find lupus pernio, usually it affects 45 to 60 years of age. So butterfly rash of SLE is an acute cutaneous condition. It typifies acute photosensitive rashes in SLE. When butterfly rash is present, usually it indicates that patient has active systemic disease. So we need to be careful in these patients. This rash extends over the cheeks like this patient, and it is also occurs over the nasal bridge. It usually spares the nasolabial fold. That is important. So SLE rash, SLE butterfly rash spares the nasolabial fold. It is usually erythematous. It can be macular, but usually it is raised with papules and plaques like this. Fortunately, it usually heals without a scar. Systemic lupus erythematosus actually was initially recognized because of this butterfly rash. The name lupus itself has come from this rash. So lupus means wolf. So when a patient has this butterfly rash, it looks like a wolf. So that's why the name came as lupus. Few decades back, one test was thought to be specific for lupus, that is lupus band test, where there is immunoglobulin and complement deposition in the dermoepidermal junction of the skin lesions, which we call as lupus band. Later on, Cormack demonstrated that in the skin of these patients where there is no lesions, if we do a biopsy and see under direct immunofluorescence microscope, we can see these deposits. There is no primary role in pathogenesis. It is positive in 60 to 70% of SLE patients, but problem is specificity. It can be present in mixed connective tissue disorders, rheumatoid arthritis, primary Sjogren's. Even 10 to 20% of healthy people can have this lupus band. So that's why it is not specific. Cutaneous manifestations are very common in systemic lupus erythematosus across different countries. Like in the USA, Dubois series with 520 patients, 70%, more than 70% patients has cutaneous lesions. From India also, different authors actually have demonstrated that 60 to 85% of patients with SLE has cutaneous manifestations. Some skin lesions are specific for lupus and some are non-specific. Lupus-specific skin lesions are acute cutaneous, like malar or butterfly rash, which are used synonymously. Then subacute cutaneous lupus lesions, which can be papulosquamous or annular or polycyclic, or it can be discoid or neonatal lupus erythematosus. And there are many non-specific lupus lesions like bullous lesions, erythematosus, which is called as lupus paniculatis. Alopecia is not specific for lupus, vasculitis, urticaria-like vasculitis, livedo reticularis, more common in antiphospholipid antibody-positive patients, Raynaud's phenomena, photosensitivity, oral ulcers, nail senses, rheumatoid nodules. So these are non-specific lesions found in SLE patients. This is an example of acute cutaneous lesions where there is erythematous lesions over the fingers and as well as in the hands. Then subacute cutaneous lupus erythematosus lesions are non-itchy, dry rash, they do not scur, they are photosensitive, that's why found in sun exposed areas. So they can be annular or polycyclic or papulosquamous, where you can see scaly bumps. There can be vasculitic lesions with purple spots, or there can be lumps because of nodular lesions. This is one example of Papulosquamous lesion of subacute cutaneous lupus erythematosus. These are examples of vasculitis rashes in lupus. Then chronic cutaneous lupus erythematosus lesions. Discoid lupus is most common form of cutaneous lesions. They are painless and non-itchy. Problem is scarring and discoloration when they heal. They are coin-shaped, and in 80% of the patients, they are located in the face and scalp, but they can be seen in other parts of the body as well. When discoid lesions occur in the scalp, permanent alopecia can result. And we should remember that when discoid lesions are present, there is a risk of skin cancer. So most of the patients of DLE, they don't develop systemic fissures, but systemic lupus patients, 15 to 1/3 of the patients can have discoid lesions. And 5 to 10% of SLE patients have discoid lesions as presentations. If the patient does not have systemic fissures, only has discoid lesions, 5% of patients with discoid lupus later on develop systemic fissures. More common is 20 to 40 years. Female is to male ratio is 3:1 to 3:2. 30% of the patients, 30 to 40% of the patients with discoid lupus erythematosus, ANA is positive usually in low titer. Only 5% of patients, high titer ANA is positive in discoid lupus erythematosus. More common is single-stranded DNA. Double-stranded DNA positivity is uncommon in discoid lupus erythematosus. But in lupus profundus, that is another form of chronic lupus lesions, N is positive in 70 to 75% of the patients. This is one example of discoid lesions, but it can be more florid-like in this patient. This is lupus paniculatis, where we can see multiple erythema nodosum all over the body.